This lecture is about pediatric ophthalmology. Children may be presented to us with different eye problems like leukocoria, which may be due to congenital cataract, retinoblastoma, retinopathy of prematurity. The child may be presented with a childhood glaucoma, nasolacrimal duct obstruction, squint, errors of refraction, amblyopia, ptosis. This lecture will be focused on leukocoria, childhood glaucoma, and nasolacrimal duct obstruction. First, we look at this picture. Which eye is healthy and which eye is abnormal? When looking to the left eye, the reflex here is normal, but on looking to the right eye, there is white pupil, a sign which is called leukocoria. Leukocoria means white pupil, which is a pathological sign in children. The most common causes of white pupil in children: congenital cataract, retinoblastoma, retinopathy of prematurity, persistent hyperplastic primary vitreous, Coats disease, and retinal dysplasia, and we will discuss each item. First, congenital cataract. What is meant by congenital cataract? Normally, the lens is clear. So, congenital cataract means opacity in the lens, which is discovered at birth or soon after birth in the early years of the child. It may be due to hereditary cause, which may be genetic, and may be positive family history. The child may have other brother or sister with the same problem. It may be intrauterine infection, such as rubella. May be metabolic disease causing opacity in the lens, as galactosemia. May be due to malnutrition, and the most common is iron and calcium deficiency. Different causes can be presented with congenital cataract. Defective vision of her baby. The baby is not fixating to objects, not fixating to his mother, and so on. So, may be presented by different symptoms. White pupil or leukocoria in case of dense cataract. Sometimes there is no white pupil and may be presented by squint due to diminution of vision in this eye. Then we start to examine the child. We may examine the child on a slit lamp as adult, like this picture, or we may need to examine the child under anesthesia, like this picture, when the child is uncooperative. On examining the child, we can see opacity in the lens. There is cataract or opacity in the lens. We have to examine the fundus if it can be examined to exclude any retinal anomalies. Sometimes the fundus cannot be examined due to the dense cataract. We have to assess the vision of the child. If the child is old and cooperative, we can assess the vision with the usual visual acuity charts like this. See letters used in adult. But in younger children, non-verbal children, he is not speaking and he is not cooperative, we can use other tests like preferential looking test or visual evoked potential. Sometimes we need to do some lab tests to this child to exclude metabolic disease as a cause of congenital cataract, like galactosemia. Maybe also nuclear cataract. Another type is the nuclear cataract, affects the nucleus in the center of the lens. Again, this picture is a summary of different types of cataract. Maybe anterior, maybe zonular or lamellar, affecting zonules of the lens and the rest of the lens is clear. Maybe anterior polar or posterior polar, anterior polar affecting the anterior capsule, posterior polar affecting the posterior capsule, maybe coronary affecting the periphery but the center of the lens is clear, maybe punctate or blue dot, maybe sutural taking Y or inverted Y suture, anterior or posterior, maybe total, taking all layers of the lens. If the child has dense opacities, this may lead to nystagmus, squint, amblyopia. There is deprivation. The light is not entering the eye, especially when starting since birth. So there is nystagmus, abnormal movement and vibration of the eye, and may lead to amblyopia, diminution of vision of the eye even after correction of the cataract, and squint due to deep amblyopia. How can we treat a child with congenital cataract? First, we can differentiate. If the case is unilateral, the unilateral cataract is more dangerous. Why? Because single eye is affected and the other eye is normal. So he is very liable to amblyopia in the affected eye. So he must be operated as early as possible to avoid amblyopia. And after operation, we have to do amblyopia therapy for the child, as you discussed in strabismus. Amblyopia therapy is done by occlusion of the normal eye for certain time every day for training of the diseased eye after surgery. So unilateral cases is more dangerous. Must be treated early. In bilateral cases, it will depend on the density and symmetry of the opacity and visual acuity of the child. If the visual acuity of the child is highly affected, or the cataract is dense, I can't see the fundus behind it, the child is not seeing through it, so it must be operated. The treatment of congenital cataract is surgical. Surgical treatment may be done either through irrigation aspiration. We go for aspiration of the lens matter and irrigation with saline, or lensectomy in some cases, removal of the lens cortex and the capsules, and removal of the anterior part of the vitreous by vitrectomy machine. So the first step in treatment of this child is surgical removal of the cataract, lensectomy or irrigation aspiration. After removal of the cataract, the child is aphakic. This is the first and most common cause of leukocoria in children. The second cause is retinoblastoma, which is here the most serious or most dangerous cause of leukocoria in children. Retinoblastoma is the most common primary intraocular malignancy in children. Usually start before the age of 3 years. Very rare cases after this age. Maybe positive family history in 6% of cases. Some children has other siblings with retinoblastoma. Bilateral in 20% of cases and unilateral in about 80% of cases. It may be caused by mutation in a gene on chromosome 13. Here the child can be presented by one of these presentations. May be presented by leukocoria, white pupillary reflex, in 65% of cases. May be presented by squint. If the tumor is affecting the macular area and the vision is very poor, there is amblyopia and the squint of the affected eye. The parents here may come to you complaining of squint, not leukocoria. May cause secondary glaucoma, elevation of intraocular pressure, and there is pain in the eye. May be presented like this case with proptosis. If the tumor extends outside the eye, extraocular extension, mainly behind the globe, and push the globe forward, so may cause proptosis, protrusion of the eyeball forward. And sometimes may not be presented by any of these symptoms: no leukocoria, no squint, no secondary glaucoma, no proptosis, and no complaint, and just accidental discovery of retinoblastoma by routine examination of the child. If we face this case, how can we diagnose or confirm the diagnosis of retinoblastoma? The first, we have to do ophthalmoscopy, means examination of the retina or of the fundus. And it is very important, even the child is complaining or presented with single eye, we have to examine the other eye carefully, because bilateral cases may be present in 20% of cases. Then we can do, the tumor here is, according to pathology, is characterized by calcification. So we may need to do X-ray to show tumor calcification. But better than X-ray in this age group, we can do ultrasonography like this, ophthalmic ultrasonography like this picture. We see here the mass filling the vitreous cavity. We can do CT, computerized tomography of the orbit, and we can do MRI. In CT and MRI give us a picture also of extraocular extension of the tumor, if there is any extraocular extension, or optic nerve invasion. How can we treat the case? According to the stage of the case. If the retinoblastoma is diagnosed in the first stage, which is called quiescent stage, there is no glaucoma, there is no extraocular extension, there is no distant metastasis. Here, if it is of a smaller size, we can treat it with laser photocoagulation to do damage in the tumor cells, or cryotherapy, or radiotherapy, or transpupillary thermotherapy. All of these items aims to cause damaging of the tumor cells and prevent spread of the tumor. If the child is presented with secondary glaucoma, no way, we have to do inoculation, removal of the eyeball with part of the optic nerve, excision of a long stump of the optic nerve to ensure if there is optic nerve invasion. If there is extraocular orbital extension, we have to do what is called orbital exentration. Not only removal of the eyeball and stump of the optic nerve like inoculation, but also removal of muscles and other layers of the orbital cavity, contents of the orbital cavity. If there is distant metastasis, so we refer the child to get systemic chemotherapy. Again, to differential diagnosis of leukocoria in children, we explained here congenital cataract and retinoblastoma. Other causes may be retinopathy of prematurity. Retinopathy of prematurity occurs if a baby is born premature under 32 weeks gestation and birth weight is less than 1.5 kilogram. The baby here is exposed to failure of vascularization of the periphery of the retina, especially if the baby is exposed to incubation and high oxygen concentration. And this disease is highly dangerous if not diagnosed early and managed early, because it may end with fibrosis in later stages. So any baby born before 32 weeks gestation, premature, and low weight, less than 1.5 kilogram, we have to do early screening and management by ophthalmologist to save this vision of this baby and prevent the disease. Other cause of leukocoria is persistent hyperplastic primary vitreous, which is a congenital anomaly. There is permanent hyaloid artery and fibrosis of the anterior vitreous. Coats disease is a disease occurs in the more common in male, more common in the first years of life, about from 5 to 10 years, with unilateral extensive leakage from retinal vessels and large masses of subretinal lipid accumulation, so give us a picture of leukocoria. Retinal dysplasia is a congenital chromosomal defect, has a genetic factor affecting the development of the retina. There is disorganized retina, give us leukocoria. The second item in this lecture is the childhood glaucoma. Can you see these pictures of this child? They have large cornea, what is called megalocornea. There is edema of the cornea, abnormal coloration of the cornea, differs in severity from mild to severe cases. This is what is called the childhood glaucoma or congenital glaucoma. Congenital glaucoma may be primary or secondary to another congenital anomaly in the eye or anomaly in the eye. Primary congenital glaucoma means elevation of intraocular pressure due to developmental anomaly in the drainage angle of the eye. There is defect in drainage of the aqueous fluid in the trabecular meshwork and the iridocorneal angle. So accumulation of the aqueous fluid inside the eye, and due to the laxity of tissues in the baby, elevation of intraocular pressure will cause enlargement of the globe and stretching of the eye cuts. This baby can be presented early with photophobia, lacrimation, blepharospasm, which is the earliest symptoms in these babies. If late presentation, it will end with large eye and ophthalmos. When we examine the baby, the cornea, we can see here ophthalmos, which means increase in the diameter of the cornea more than 12 millimeter, and we can see corneal edema. The sclera is stretched and thin, and sometimes very thin, that the uveal tissue shines behind it and giving us blue sclera, blue appearance of the sclera. The anterior chamber of the eye is deep due to enlargement and stretching of the globe. The IOP is high. The optic nerve, like what occurs in adult glaucoma, there is cupping of the optic nerve, like this picture. Later on ends with atrophy. When we examine the angle, we will see here by gonioscopy, we will see angle anomaly due to maldevelopment of structures of iridocorneal angle, which is the main pathology in these babies. We have to exclude other causes that may be misdiagnosed with primary congenital glaucoma. Other causes of large cornea as congenital megalocornea. Here the cornea is large, but there is no corneal edema, there is no elevation of intraocular pressure. This is called congenital isolated megalocornea. High myopia, sometimes with high myopic eyes, due to increase in the axial length of the eye and increase on the size of the eye, there is large cornea. Keratoglobus is a bilateral condition There is enlarged size of the globe, and the cornea also is enlarged with familial incidence, but the cornea here is clear. So we must differentiate primary congenital glaucoma from these causes of large cornea. Primary congenital glaucoma is presented with corneal edema and cloudy cornea, but there are other causes that may cause cloudy cornea at birth, as birth trauma, metabolic disorders, congenital rubella syndrome, which we must exclude. We must differentiate primary congenital glaucoma from secondary congenital glaucomas. There is another pathology in the eye which causes elevation of the intraocular pressure, like retinoblastoma, uveitis, aniridia, ectopia lens dislocation or subluxation of the lens from its position, and so on. The treatment of primary congenital glaucoma is mainly surgical, cannot be managed medically. We do angle surgery as the main lines of treatment to correct the pathology in the iridocorneal angle. Two operations can be used, goniotomy and trabeculotomy. Both operations aims to correct the anomaly in the angle and improve the drainage of the aqueous fluid inside the eye to decrease the intraocular pressure. And the last item is the congenital nasolacrimal duct obstruction, what's called congenital or infantile dacryocystitis. Here, the child will present to you with epiphora, means watery eye, usually in the first 2 to 3 weeks after birth. In this disease, there is imperforate Hasner valve at the lower end of nasolacrimal duct. So there is obstruction of the nasolacrimal duct. So there is defective drainage of tears through the nasolacrimal duct. So the child will be presented with epiphora or watery eye soon after birth. If we press over the lacrimal sac, we will see a reflux, positive regurg of clear fluid or mucus or pus, sometimes mucopus, regurgitated from the punctum due to obstruction of the nasolacrimal duct, and maybe secondary bacterial infection may occur on top of this obstruction. We can treat this child first with conservative treatment, antibiotics to treat or prevent secondary bacterial infections, and this massage. We instruct the mother to do hydrostatic massage of the lacrimal sac as shown in this picture. The mother press on the lacrimal sac and go into downward direction. She has to do this different times through the day. This helps to remove any remnants of the epithelium or to open the valve that obstruct the nasolacrimal duct. We will try with this conservative treatment up to 6 months after birth, sometimes up to 9 months after birth. The second, if conservative treatment fails and still the child has the same problem, we may need to do probing. Probing is successful if done carefully, as the lacrimal passage are still elastic. We do probing of the lacrimal passage by special probe before 1 year age. Repeated syringing and irrigation with saline may cure the condition and overcome the obstruction of the nasolacrimal duct. If all these measures have failed, we can go for surgical treatment by 2 types of surgery, either silicone intubation or dacryocystorhinostomy. Silicone intubation of the lacrimal drainage system. If the probing failed to cure the obstruction, the tube, we put a silicone tube in the lacrimal passage to maintain it patent, and the tube tube should remain in its position for 6 to 12 months. If this failed, we can need dacryocysto-rhinostomy operation to overcome these obstacles. Thank you.